to introduce ourselves to you. I know many of you, I have talked to a lot of you along the way. And again, we're so happy that you're with us today. Beth Hersher, Program Manager for Constellation Quality Health for the ACE Leadership Academy. And I have, you just heard from my colleague, Anne Louise Moran. She is also a staff at Constellation Quality Health and will be supporting, we both will be supporting David Farrell, who is consultant for us and also is going to be your faculty and your coach. You're going to get to know David very well through the next 6 months, and we are just delighted to have him a part of our team as we move through the collaborative together. So ACE Leadership Academy, it is a long-term care learning collaborative to strengthen frontline staff retention as the foundation for high performance. It is a collaboration with South Carolina Department of Health, or as you know, DHEC, and it is funded through the American Rescue Plan Act of 2021 under the Nursing Home, Long-Term Care Facility Strike Team, and Infrastructure Project. A brief overview, and as I just stated, David is going to dive a little deeper into phase 1, phase 2, but this project was, and we did deploy this in 3 phases, if you will, or 3 years. Phase 1 was October of 22. You're going to hear about our on-site visits with 8 high-performing nursing homes and really how that set the foundation for phase 2, which was from January through September of last year. And that's where we worked with a very small cohort of nursing homes. David was also coaching and facilitating those coaching sessions. So he's going to share more about that with you. And then currently where we are right now is phase 3. We are in, we'll be working with you from January through September. This collaborative is another way for us to spread what we learned during phase 1 and phase 2 with all of you. And then you're going to hear about 2 additional programs that we've developed to assist you with your frontline staff retention. So this is just a graphic because it's just so you can visually see what we're talking about when we talk about the bundle of opportunity. Phase 3 is the ACE Leadership Academy Phase 3. It's our 2024 program, and it is free access to resources to improve workforce retention and strengthen staff stability. I'm going to start at the bottom of this graphic because that's where we are today. We are kicking off our Leadership Learning Collaborative, and we're inviting key leadership administrators, assistant administrators, DONs, ADONs, and other key leaders that you feel would like to participate in this 6-month collaborative. And the other 2 programs is Frontline Supervisor Support Training Series. It's a web-based training module. We're inviting nurse managers. Anne Louise is going to share more about that in just a second. And then I'm going to share a little bit more about the CNA preceptor program, and that's where we're working with CNAs, staffing coordinators, and facility educators. Real quickly, we wanted to share with you the expectations of this learning collaborative. And of course, our initiative goal is to assist you and for you to learn how to strengthen your frontline staff retention. We're going to be doing that after this kickoff. It'll start in May and we'll go through September. This screenshot that you're seeing here will be given to you following this kickoff, and it has our schedule, it has the dates. But we'll be doing the second Wednesday of every month. We're going to offer you a 60-minute learning session. You'll be David will be facilitating that, and there'll be various topics, again, with this goal around to strengthen your frontline staff retention. And then the 4th Wednesday of each month, we'll be coming back together for what we're calling a quick Zoom coaching session. And those are going to be where you can engage and share with one another and talk about what you're testing out and some of the interventions that you're doing. Following this webinar, you will get a Zoom registration link where you can register for the entire series and the coaching sessions. The collaborative is for us everybody to teach and learn. If we want it to be active participation, David will be providing you some practical approaches, discovery and implementation. So everything is going to be very practical, easy to do, and the whole idea for this collaborative and these coaching sessions is so that we can learn from each other. And with that, I am going to turn it over to David for the remainder of the program. David?
Great, thank you. Thank you, Beth, and welcome everybody. I'm David Farrell. I'm a nursing home administrator here in California and happy to be a consultant on this project. Next slide. So this whole project started back in 2022 when we all had to come to the realization, I guess, that the bottom had fallen out. Staff were leaving in droves. And we had to face the facts that we had a problem with the quality of the jobs we were offering. The bottom really fell out in 2021. For the most part in 2020, staff stepped up. And the South Carolina Institute of Medicine really called on the leaders of long-term care facilities to do something about it. And we at Constellation Quality Health decided to do something about it with you. Next slide. Throughout the United States, nursing homes lost staff in droves over the course of the pandemic. And for the most part, we haven't really recovered. Recovery has been very, very slow in the nursing home sector. And the impact on local healthcare systems has been profound as nursing homes who don't have enough staff have to reduce the number of new residents that they admit. And as a result, in many communities, skilled nursing level residents languish in hospital beds for months waiting for a nursing home bed. And it's all triggered by the loss of our staff. Next slide. Other sectors of the healthcare system also lost staff, but they recovered more quickly. In fact, home health, outpatient care, booming with new hires in 21 and 22 as nursing homes continued to languish. We really had to look inward. We had to look in the mirror and we had to figure out how do we create a better quality job for our staff so we can compete with hospitals and home health care agencies and physician offices. Yeah, so let me walk you through each phase of the project and give you a glimpse of phase 3 that you're participating in. Next slide. So our work began in phase 1, and this was exciting work. What we did is we identified 8 of the highest performing nursing homes in South Carolina over the course of the pandemic up until that point. So we identified facilities with low COVID case rates, low mortality rates, low hospitalization rates. We then cross-referenced that data with CMS Care Compare star ratings and focused infection control survey and certification results to identify these top 8 facilities. We called them the outliers because indeed they beat all the odds. They achieved a level of performance that the facilities across the street from them could not achieve. And we needed to figure out how they did it. So to do so, we went on site and conducted structured interviews with the leadership teams of each one of these 8 high-performing facilities in South Carolina in order to identify what they did and what could be replicated in other nursing homes across the state. Next slide. And what struck us was there were many key common variables amongst this group, but one of them that really struck us was their staff stability. And in particular, what the leadership team did during the worst parts of the pandemic to sustain staff stability, to keep their staff. And while many nursing homes were facing a large exodus of CNAs and LVNs and RNs and housekeepers, not the 8 outliers. They managed to keep their staff. And how did they do it? Well, they did a lot and they invested a lot. But starting with consistency, what we heard over and over again was that the leadership teams were obsessed with the infection control guidance, and they pored over every guidance change, and they had a method and a process to communicate the changing guidelines related to COVID with their staff. They held their staff to very high expectations, but at the same time, they were constantly showing the staff how much they valued them, cared about them, and cared about their family as well. They developed trust by communicating regularly about the staff and being humble enough to know when they didn't have all the information and letting the staff know the truth of what they did know. But in essence, what we saw was that they created the precise conditions for their staff to stay. They weren't lucky, they did things. And in many cases, they were practicing what we call the evidence base of leadership in long-term care facilities. Next slide. One of the key pieces that we noticed amongst the outliers was how much they spent on morale and recognition of their staff. They were not cheap. They did not try to keep their morale boosting events at a low budget. They spent money to tell the staff how much they cared about them. Some were spending upwards of $6,000 a month in discretionary spending to show how much the staff they cared about the staff. But the things that they invested in were very visible and very meaningful to the staff. And one facility that we visited, we came at a time when school was about to begin in September. And they showed us a big dining room with bags of school supplies for all of their staff who have kids who are in school. Of course, not all their staff are going to get a bag of school supplies, but for the staff who are parents of school children, this was a very meaningful and gesture on the part of this leadership team. Did it cost them money? Sure it did. Will they get a return on their investment through the commitment from those parents? Yes, they will. So it's these wise investments we saw. But again, they weren't trying to cut corners. They didn't do it cheaply. They bought real trophies. They had wonderful decorated cakes for the staff to enjoy. They didn't just throw pizza parties at the staff. When staff achieved certain milestones related to quality improvement, they got trophies, they got cakes, they got more rewards. So tying their investments to quality improvement was a key strategy amongst all the outlier teams that we visited. But they also focused on culture. They had rituals, they had staff talent shows, they had spring proms for the residents and staff. It was all about community and culture in these organizations, and that's what kept the staff and the leadership team connected. The leaders that we interviewed had a unique way of balancing strict adherence to infection control practices, while at the same time balancing compassion and flexibility at this really difficult time for their staff. In so many cases, they really lean to the far right here on compassion and flexibility. But when they saw a staff member who wasn't wearing their N95 correctly, they said something, and the staff responded. Sure, let's talk about phase 2 now, before we transition into phase 3 that you signed up for. So in phase 2, our goal was to take some of the key lessons that we learned from the 8 outlier facilities in South Carolina and bring them now to a diverse group of 12 nursing homes in South Carolina, in the hopes that we could trigger them to implement some of those key evidence-based best practices that we saw in the outliers. So to do so, we went on site to each of these 12 nursing homes for visits and for gathering information and doing interviews on 2 occasions. In between those on-sites, we conducted virtual coaching sessions, and we all came together for a final outcomes congress last October. And this was truly a very diverse group of 12. Well, the first 8 that I described, the outliers, they were all 5-star homes. They were all really high-performing facilities that achieved the great outcomes through the pandemic. This group, well, a few of them could be considered outliers. They were much more diverse. And we had an even split of for-profit and not-for-profit facilities in the state. We had quite a range amongst their star ratings, stability, staff stability, as well as financial stability. And what we shared with the 12 nursing homes was a breakdown of the specific high-value interventions that drive staff stability. And we broke it down into 3 what we'll call buckets, okay? And each one of these buckets, management practices, financial investments, human resource practices, have specific interventions that may work in your organization. So this is kind of like a menu, if you will, of practices that are well grounded in the research specific to nursing homes, specific to leadership, specific to staff stability, recruitment, and retention. When we refer to the bundle, what we're talking about here is that you really can't just pick one menu item and expect to get a return on that investment. Oftentimes, we find that facilities need to take a couple of different management practices and start implementing them or refining how they implement and practice those. They need to take maybe 2 or 3 financial investments off the menu and a couple of HR practices. And when you do that, now you've created a bundle of interventions that is likely to move your data. So this concept of bundles of interventions or bundles of best practices has been well grounded in the quality improvement movement in the United States. It's been embraced by the Institute for Healthcare Improvement. And what it is, it's a structured way of improving processes of care. And it relies on a small set of 3 to 5 evidence-based best practices that when staff and leaders perform them collectively and reliably, they've been proven to improve patient outcomes. And in this case, we're stretching the efficacy of this concept of a bundle to human resource practices, in particular staff stability. So what makes a bundle work is the reinforcing nature of the specific interventions that you select. What we've learned over time and consulting with nursing homes, as well as learning just trying to implement change in a nursing home as an administrator, is that many best practices fail, and they fail to be implemented, and they fail to last because they're not surrounded by other best practices that support it. In other words, there's no reinforcing nature there, and as a result, things tend to fizzle out or fail. So here's a visual model, if you will, of what one of you might might proceed with in the course of this collaborative. So I showed you the menu, if you will, of the bundle of all the practices and the 3 buckets. You might take a close look at those and with your leadership team, start to select a few that might work best for your organization to create more staff stability. And perhaps you choose these 3 under HR practices that you're going to improve staff attendance and trigger reliability by working closely with them on their scheduling. You're going to find a way to incentivize stability and growth by embracing the NACA peer mentor program and giving CNAs an avenue to move up in the organization. And you've decided that you're going to revamp how you hire new people and how you welcome them in your organization. And those are the 3 in that particular bundle. But that's not enough. Over in management practices, you decide, you know what, we don't do enough rounds, or we don't have the huddles that we should have. Really, we just have nurses giving reports. So let's tackle that. And with our huddles, staff will be feeling like they're included. Or perhaps we can tackle getting the CNAs to attend care conference meetings so they feel included. And by the way, we're going to have a spring prom for the residents and staff with a live band in order to build community. Okay, those are our 3 selections under that bucket. And then on financial benefits, we're going to take another look at our wages and benefits. We're going to do another wage analysis, if you will, but not just wages. We have to do an analysis of the whole package that's being offered by our competitors. And that includes not just wages, but benefits, what the staffing levels and workload are of our competitors, and what kind of quality of job that they're offering that maybe we're not. What we learned in the first 2 phases was that all the nursing homes we worked with raised their wages. They all raised their wages. They had to stay competitive. And for the most part, their wages were quite similar. But they got different results. And they got different results because, as you see in this quote, if staff don't really trust the leaders, they never really trust their rate of pay is fair. So amongst the 12 in phase 2, we did this little comparison chart as we moved along and got to know these 12 facilities very well. And of course, as I mentioned, all 12 raised their wages numerous times to stay competitive and try to keep their staff over the course of the pandemic. However, the 6 facilities you see in the middle here took a different approach after raising wages. For example, on average, the 6 facilities in the group, I don't know how to refer to them, but the 6 facilities on the middle column invested over $1,500 a month in employee morale and recognition. 6 facilities in the far right invested no more than $200 to $300 on morale each month. The star ratings for the 6 in the middle was 4 to 5 stars on average. The star rating for the 6 on the right was 1 or 2 stars. For the 6 in the middle, 5 out of 6 were beating their budgeted profitability goals. For the 6 on the right, none of them were beating budgeted profitability. For the 6 in the middle, they were all staffing above 4.00 hours PPD. For the 6 on the right, they were all staffing at about 3 hours per nursing hours per person per day. The accruals and holidays were quite different. In the middle, the 6 nursing homes were offering up to 19 paid days off a year, 3 to 5 holidays a year, and also at least 3 days of bereavement if needed. The 6 on the right were offering 10 to 12 days a year, in some cases 1 holiday a year and 1 bereavement day. The ratios for the CNAs were vastly different on the day shift. The 6 in the middle, it was 1 CNA to about 6 or 7 residents. For the 6 on the right, it was 1 to 10 to 11 to 12 residents. So the key question here is, how do nursing homes make money? Do they make money by cutting corners and trying to do things as efficiently as and maybe cheaply as possible? Or the group in the middle, do they invest, and do their investments pay off? So as we move into the phase 3, what we hope to get you to focus on over the course of the webinars that we'll go through over the next few months is just how impactful you are. Without a doubt, nursing home administrators, directors of nurses, infection preventionists, DSDs, these individuals carry a lot of weight. Your words and actions are highly impactful. There's something about the organizational makeup of these fragile ecosystems we call nursing homes that make them particularly susceptible to poor leadership practices. However, at the same time, because of their fragility, they're also super responsive to leaders who are doing the right thing and practicing the evidence base. We'll be constantly focused on both the science and psychology of organizational change with you over the next few months. On the science side, we know that quality improvement happens when we focus on evidence-based solutions, when we test things before we roll them out throughout the organization, when we're constantly evaluating and reevaluating through collecting data on both outcomes and processes, and when we're willing to make mid-course adjustments based on the staff who are giving us feedback and are doing the work. The psychology of change is all about relationship-based practices. And we all know, because we've tried it, I'm sure, it's almost impossible to implement change if the staff don't want it. So you have to work with the staff. You have to build in the capacity for the staff to accept the change. And that only happens by developing relationships over time. High-performing organizations in our field have 3 very common elements. Their culture is focused on the residents. They're delivering and living person-centered care, and you can feel it when you walk in. To do that, they have a committed workforce. They have low absenteeism. They have low turnover. They have high retention. And they have high morale, and they measure it constantly and look at the data. But foundational to it all, they have leaders like you who are practicing the evidence base. They are making it happen. The theory of relational coordination fits well in our settings because staff rely on each other to get their work done. Residents create uncertainty, and everybody's working under strict time constraints. So the theory of relational coordination basically assumes that we can deliver high quality of care because the staff are in good relationships. Most of our policies and procedures assume the staff are communicating well. Our policies and procedures assume the staff are getting along. If the staff aren't getting along, they don't follow policies and procedures that force them to interact with people they don't want to interact with. So the theory of relational coordination is simple to understand, very difficult to implement, but it basically goes like this. The effectiveness of care and service coordination in a nursing home is determined by the quality of the communication amongst the staff, which depends on their underlying relationships. The quality of the relationships reinforce the quality of the communication. You measure relational coordination and you measure whether or not you're communicating by looking at all the meetings that you have, who attends the meetings, what the agenda is, and who gets to talk. You also measure the health of the relationships in the organization by determining whether or not the staff and leadership teams have shared goals, shared knowledge, and mutually respect one another. Deming, the godfather of the quality improvement movement, was all about the relationships. He said that you can't improve complex interdependent systems and processes of care in a nursing home until you progressively improve the interdependent interpersonal relationships amongst the staff. Indeed, quality is all about relationships between the coworkers, across departments, between supervisors, between the staff and residents, and between the residents themselves. Quality in a nursing home starts with relationships. What drives staff stability? The perception that the leaders who attend your leadership stand-up meeting in the conference room care about them. The perception that the management team is willing to listen, the perception that the leadership team is helping to reduce the stress on the job, having enough equipment and supplies, and your individual supervisor caring about you as a person. The drivers of staff stability have been well known in nursing homes for over 20 years. It's the execution and implementation of the processes to get the staff to see how much you care and listen and how much you're doing to reduce the stress. These are the keys. The staff are very perceptive of the leadership team. Staff are always watching you. They're always eavesdropping on what you're saying. They notice who you talk to. They notice how often you talk to them. These are smart, perceptive individuals. So there's an infrastructure that we see for high involvement and high performance in nursing homes, and it starts at the bottom, and this is what we're trying to achieve with you. But it also encompasses the bundle that you see here. It starts with staff stability and consistently assigning those staff to the same groups of residents next to the same coworkers day in and day out, because person-centered care relies on the staff deeply knowing the residents, not superficially knowing the residents. And when staff deeply know the residents, they have a lot to share with the interdisciplinary team about what they know. And when you give them a venue to share it, like a huddle, it invigorates the staff. It engages the CNAs. They become the expert on their group of residents. And now via huddle, you have a way for them to share what they know. At the next level is leadership teams doing rounds and stopping and taking the time to talk to the CNAs and LVNs, making observations of what they're doing and how they're interacting, and doing what you can to hear from them and learn and support them who are doing the work with the residents. And then finally at the top, if you can achieve getting the staff to attend both the care plans that they're in charge of executing, as well as the quality improvement meetings, so that the staff doing the work have a say in what changes are coming next. What we hope to try to help you to achieve is the highest level of employee engagement. And that's when your employees actually show and demonstrate this discretionary effort that reflects how much they care and love the residents that you have there. Engaged employees making this discretionary effort above and beyond their job duties. These employees are deeply connected to you and your organization. They're connected emotionally, socially, and spiritually. And we encourage you to embrace that.
I know we're pressed for time, but I do want to share with you about measuring and tracking your progress. And David had alluded to some of this when he talked about the importance of tracking and knowing what is working, especially when you start taking a look at those interventions and what is working, what is not working. We know that sharing of data is a way to adopt new ideas. So we're going to be pulling that information in through the coaching sessions and also through David's didactic learning session topics with the monthly learning sessions. We know that you understand process and outcome measure. You as leadership look at that and deal with that every day. But the aggregate data that we're and I'm going to share with you in a moment that we would like to collect some real-time data from you is going to help us with that information so that we can share that with your peers. And you all, again, learn from each other through information through the data collection. So we're just modeling a model for improvement. David mentioned IHI, and that is we probably all know this because of our QAPI or QAPI projects that we're all doing. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? So we just felt like this IHI model aligns right back with those bundles of interventions that David will be coaching us through. And we're going to provide you a very short worksheet following this kickoff. And that worksheet is just for you to self-assess, take a look at the bundles, and just identify those areas. David kind of gave you an example of how to utilize the interventions in a bundle. So we want you to just think about that and do that as your homework before we come back together next month. That will help you with your action plan. And then we are going to be asking for you to submit some real-time data. I don't think that this is new. I'm sure as leaders in the facility, you can put your finger on this data. But we do want to take a look at your direct care staff turnover. We're saying direct care staff because we're talking about frontline staff. It also aligns with your PBJ. So we're talking about your RNs, your LPNs, and your CNAs. And then we want to know your new hire retention rate, your number of new hires in the last 90 days that are still employed over the total number of new hires within the last 90 days. And then I'm so excited to get your feedback on those absenteeism. We are asking if you could just give us every month your unplanned monthly callouts. David has a wonderful couple of sessions, I'm sure, that he's going to incorporate some of the tips and suggestions for you on how to manage that. Don't get too bogged down off of these bullet points. The link that we'll be sending you when you get to that form, it's going to give you clear instructions. It even tells you how to calculate like the direct care staff one does, so that all you have to do is drop it in for us. And then what are we going to do with that data? Well, we are going to turn that data into information, hopefully for you by doing an analysis. We are going to be developing. It's either going to look like a trend graph or a progress report. We'll be sharing that with you as we move through and get more of the data. And then we're going to be reviewing that during our coaching sessions. Again, data is just information, right? It's information to help you improve your goals. And so that's what we plan on doing with it from what you submit to us on a monthly basis. And with that, we're going to share with you your Care Compare data. And Louise is going to, I know you know this, but January 2024, there was a refresh with Care Compare. And we just thought we would close our time with you today about the importance of looking at data. And so, Anne Louise, I'm going to turn it over to you to share.
I'm going to do this in less than a minute. So you can time me on it. So we're just looking at we understand that there's a lag time in reporting, but we wanted to get some overall benchmarks to see where we are. So we're going to be tracking our overall star rating. And as you can see here, it's the ratings go from 1 to 5. And at the very bottom, you'll see the number of facilities that are participating in this peer group and how they were ranked. So for example, there are 4 facilities that have a 5 overall star rating. The collaborative average, this peer group is listed at the top as well as the state and the national average for January. If you go to the next slide. Same thing we did for the staffing star rating. Again, there were 8 facilities that had a 5-star rating for staffing, 3 facilities that had a 1-star rating, and then the averages again for January are up in the box on the left. And then finally, this is just a different way to look at data. It's actually ranking all of the turnover from the January Care Compare, and just ranking them and putting them into groups. And so you'll see that the lower is better. So in the less than 10th percentile, there were 3 facilities that had a rating, turnover percentile of 39.9%, versus there were 3 facilities at the opposite end that had a greater than a 72.4% or greater turnover. Again, the averages are in the box on the side, just something that we're going to be keeping an eye on that you don't need to worry yourself about. We're just trying to do some benchmarking. Turn it back to you.
Yeah, thank you, Anne-Louise. So next steps really quickly, there's going to be a follow-up email, and we'll have a registration link in that email for you to register for the entire series. You just have to do 1 registration and you're in. We'll be sending out Zoom session reminders. We'll get our cadence on that. So you should have it on your calendars, because when you register, Zoom automatically should send you a calendar invite, but we'll help you out there. You're also going to get that schedule that I talked about early. And then we'll remind you to do that. Just give us those quick little self-reported data. And then just a sneak peek, we're going to be with you again on May 8th. This is going to be the first learning session that David will be facilitating for you. And then we will come back again during May, on May 22nd, and that's when we're going to do our coaching session. Just a sneak peek of what David is going to share with you. He's going to talk a little more about those outliers and lessons learned, and talk about how those management practices generated positive staff and resident and organizational outcomes. You'll be able to hear and explore evidence-based practices around increased infection control compliance that boosted staff vaccination rates. And of course, we're going to tie all of this in with what the leaders did consistently, repeatedly, to successfully navigate through the pandemic, and also work around staff retention as they were going through this crucial period of time. We want to leave you with Dawn Berwick, who is former president of IHI, a quote from Dawn Berwick, and really how we want to help you throughout this collaborative. It's change starts with 1 step at a time. If you can't change something big, change something small. And you're going to be able to hear that throughout this collaborative as David breaks down those interventions, and we talk about how these small changes really do make a huge difference in your staff retention. So with that, I am going to end our webinar, but I do want to see, Anne-Louise, did we have any question that we may have overmissed or overlooked? Forgive me.
No, ma'am. I don't see any here.
Oh, okay, great. Thank you. And David, would you like to say any last final closing remarks?
Thank you, everybody. Appreciate you joining. Have a good afternoon.
All right. Thanks, everybody.